Hello, good morning all. So once again, welcome to Dental Vriksha's Zoom webinar. And my sincere thanks to Dr. Jayanthkumar for giving his time to share his knowledge. And welcome all the participants for joining us. A small introduction about Dr. Jayanthkumar is a clinician. Can all the participants can mute themselves so that we can hear the speech very clearly. Thank you. Dr. Jayanthkumar is a clinician, academician, and researcher specializing in oral medicine and radiology. He completed his BDS from Savita Dental College in 2007, followed by his MDS in 2013 from Meenakshi Ammal Dental College, where he was honored as the best postgraduate student in oral medicine and radiology. He later earned his PhD from Savita Dental College in 2021. With over a decade of academic experience, Dr. Jayanth has served as senior lecturer, reader, and currently professor in the Department of Oral Medicine and Radiology at Savita Dental College. Alongside his academic career, he runs a successful independent clinical practice in Avadi, Chennai. Dr. Jayanth is an active researcher with an extensive publication record across PubMed, Scopus, Web of Science, and international conference proceedings. His scholarly contributions span oral potentially malignant disorders, radiographic diagnostics, oral cancer research, and CBCT applications. Several of his works have received notable citations, and his systemic reviews and clinical studies are widely referenced. He has been recognized with multiple honors, including the Distinguished Alumni Award from Meenakshi Ammal Dental College 2025, the Global Outreach Healthcare Award 2023, and the Best Paper Award at the 19th OOO Symposium 2022. Dedicated to advancing evidence-based dentistry, Dr. Jayanth continues to contribute meaningfully to clinical practice, dental education, and interdisciplinary research. Thanks a lot, Dr. Jayanth, for your time for Dental Vriksha. And over to you, Doctor. We are waiting to hear from you. Thank you so much for the time. Please proceed, Doctor.
Good morning, dear participants, and thank you, sir, for the introduction. So today the topic that I have taken up is on the imaging options available to us in our dental practice. Let me share my PowerPoint. Now, is a full screen view visible?
Yes, sir. Yes, sir. It's visible, sir.
Okay, sir. Okay, sir. Okay. So the topic that is taken up for today's discussion is imaging strategies in clinical dental practice, a problem-based approach. See, what I intend to convey in the next 45 to 50 minutes is that in dental imaging, we have a number of imaging modalities. We have not only plain film imaging, that is our conventional IOPs, bite wing occlusals, and orthopantomographs. And then we have another group of imaging modalities referred to as specialized imaging modalities. But please do remember that one imaging modality doesn't fit for all our clinical needs. So we will have to choose an appropriate imaging modality according to the clinical needs. So that would be the aim of my discussion. And mainly I'll be focusing only on the specialized imaging such as computed tomography, cone beam computed tomography, which is being a big revolution in our imaging field today. And we are using it very frequently in our practice, and the availability and the cost of imaging also has come down. Then we have our which has been there for quite some time, that is magnetic resonance imaging, advanced imagings like nuclear scans, and ultrasonography, which is actually a very, very cost-effective imaging modality, and it has a role to play in our imaging requirements. So we will look into each of these imaging modalities with a clinical scenario, so which will help us easily appreciate on where it can be used. Okay, just a brief history of how radiography made its inroads into dentistry. We all know that X-rays were discovered in 1895 when Röntgen discovered it, and he didn't know how to name those rays, and he referred to it as X-rays. The very next year, dental radiography had its birth. Otto Walkhoff was a person who made the first dental radiograph but the exposure time was 25 minutes, and we didn't have those conventional films that were available. It was all taken in photographic plates, which were processed and the images were read out. Film-based imaging made its inroads in 1930. Slowly, OPG came in. CT and MRI were to come back to back the next years to each other. And then we had RVG, which has literally revolutionized our day-to-day dental imaging in our practices, because it's so very easy. We don't have to go and do a processing. The moment we click it, in a couple of seconds, the image is available on our computer screen, and we do get, to an extent, interactive images, meaning we can vary the contrast, resolution, and of course now AI is also making its inroads here, wherein it is able to automatically pull out the margins of the carious lesion, so on and so forth. Then, of course, in 1993, we had cone beam computer tomography, which we popularly referred to as the third eye of dental imaging. Okay, so these are all the various advanced imaging modalities that are available in our field. So why do we need some sort of a specialized or an advanced imaging? See, all these days, our IOPAs, bite wings, occlusals, and your orthopantomographs were all two-dimensional representation. Imagine this cylinder, which is shaded blue on the inside and orange on the outside. When viewed from one direction, it portrays itself as a blue circle. When viewed from another direction, it is portrayed as a orange rectangle. Both are correct. I'm not saying that either of them is wrong, but to have a holistic approach of what actually is being imaged, we need to have some amount of prior knowledge or a subjective inference to decipher what has been imaged. So this is where we have a question of experience coming into play. So in order to overcome that came in three-dimensional imaging or specialized imaging, which was able to give us holistically what is being imaged from all different planes. So even a beginner can easily interpret those images, because as you all know, imaging is just one step in your diagnosis and to monitor the outcome of your treatment. So it has to be something which is easily understandable and decipherable by all people, so that it can improve the overall patient care of our population. Okay, that's the whole idea. And your IOPAs and bite wing radiographs had inherent magnifications, superimpositions. So these were all eliminated when we step into specialized imaging. Some simple examples we will take up. Have a look at this. Let me switch on the pointer option. Yeah. Have a look at this root canal treated lower second molar. It's neatly obturated, at least from this view that we see. It's got a crown, and this first molar is not root canal treated. Patient has a crown, but the patient reported to us with pain in this 6 or 7 region. Of course, the root of 6 shows a mild widening of the PDL. So we'll be in a fix whether it is primarily the 6 which is giving us trouble now, or is it a failing root canal which needs to be addressed in the second molar. But when a CBCT was taken and a cross-sectional view was visualized, it did show that the distal root had 2 canals which look obturated, but there is a radiolucency. Okay, so probably this root canal has some issue. So that will give us an idea that we are stepping one step forward to implore into this root canal treated teeth, rather than going and analyzing whether the 6 requires a root canal. That's the whole idea. However, this radiolucency was not visible in the IOPA because this radiolucency is confined within the 2 cortical plates, so that could have masqueraded the lesion here, and hence it is not visible. So that's sort of a limitation we have with intraoral periapical imagings, but we do not have those with our advanced or specialized imaging. Coming here. Well, this is a three-dimensional imaging of a CT. Patient comes to us with a trauma in the infraorbital lateral to the nose, somewhere over here. Some bruising can be seen. Supposing if we were to just depend on plain radiographs, we would have ended up taking an OPG initially and then going in for a PNS, where it becomes very difficult for us to know where exactly the fracture lines are present, which all bones are fractured. But when we do take a sectional CT scan, it very clearly shows where the fracture lines are, how they are extending, and it becomes easier even for a beginner to classify this, whether this is a Lafort fracture or this is an isolated fracture, and what sort of a management modality would be required, which is very, very essential to improve the healthcare to our patients. Well, with that introduction, let's get started. Now we'll start with scenario number 1. This was a 34-year-old male patient with a history of endo treatment. Patient reports of persistent pain in the region of 1415. A panoramic view here shows, well, the obturation in 1.5 looks all the way complete to the apex, and premolar, we are expected to see 2 canals, so they seem to be well obturated, and the periapical regions do not show any sort of a change. So what is causing this pain over here? Sinus is also clear. So where is the pain arising from? Is it from the root canal treated 4 or 5, or is it something else? And what you see here is the caries, but it is well away from the pulp. So this cannot be causing any sort of a pain. Have a look at these sectional images. As you can see, this is the canine, first premolar, second premolar, and these 3 are the roots of the first molar. Just keep focusing on this. So this is from the apical end. Here when you see, in the first premolar, there are 2 roots. Second premolar also there are 2 roots, 2 obturations, but buccally there is a variation where you see an extra canal which does not have an obturation, which you can easily identify it from the fact that this has got some white opaqueness in the middle. This has also got one, but this is not having one and it is black. And it is very, very uncommon for us to expect for an extra root on the buccal side in cases of a maxillary second premolar. And that too, it is like not even an extra root, it's like a split, because little higher up I can see only it has 2 roots. And here at the crown end, nothing is, this is the next slide. Here at the pulp chamber level, there isn't anything abnormal. When you come up even more, there isn't anything abnormal. So a split on the buccal side, somewhere in the apical third, might have resulted in that portion of the canal not being cleaned at all, which could have been a trigger for the persistence of a bacterial ingress into the periapical tissues, leading on to persistence of a pain. In this case, you don't have to do a complete retreatment, just remove the buccal obturation and try to negotiate into the split of the the split present on the mesiobuccal side of the buccal root, and then use an injectable sealer. It should eventually get obturated. So these sort of scenarios will be easily be diagnosed with a CBCT even before we intervene into the patient. Okay, so what is the CBCT? Just a brief idea about CBCT. This is not about radiological principles, but something which every specialist and every practitioner should know. What is the difference between cone beam CT and regular conventional or a fan beam CT? The only difference is the shape of the beam. The shape of the beam in case of a cone beam CT is conical, cone shape, while in a fan beam, it is like a narrow slit. So what advantage it gives to us? The machine can be made very small, like our OPG machines. CBCT machines are only of that size. They don't need a very high-end X-ray detector, so the room need not be super cooled or it not be extremely cool like that of a CT machine. It can be a normal air-conditioned room. And CBCT was first used in cardiac imaging, but then later they dropped it because multi-slice CT made more inroads into that. So that is why this shape of the beam allows us to use it in cases of maxillofacial regions. So what is the basic principle of any sort of a computer tomography or a cone beam computer tomography does? It's a very simple concept. Imagine this loaf of bread is to be imaged. So in reality, what we are trying to do is we are trying to slice this loaf of bread into number of smaller slices and capture the information from them. And computed allows us to bring up furthermore manipulations to these slices. just an over exaggerated example where we can cut in the slice in any shape that we want and capture the information. Ultimately, we are able to see the entire loaf of bread. So this is how the machine is going to look. So as the patient is positioned, the machine looks at one particular point. So imagine this dark black box is what is to be imaged. It is going to go around the patient and look at that same spot from different angles. And these are the individual images that are captured as it looks at it from different sides of the patient, and it is reconstructed back. Some important terminologies that we need to keep in mind, because when we are referring a patient for CBCT scan, we should be aware of these terms. First term is region of interest. What do you mean by region of interest? Region of interest is what is the clinician interested in. When a scan is being taken, the clinician will be interested in some particular tooth. Say, for example, if you look into the same case, our area of interest in these in the CBCT case that is projected is 14, 15, and 16. So that is going to be the region of interest of the clinician. Field of view is what the machine is going to look at it. One main thing that you must keep in mind is your region of interest. Like field of view is what the machine is going to look, and the region of interest is what the clinician is interested in. One important step to be kept in mind is the region of interest should be into the FOV of the machine. What does it mean to us? When scan centers come to us and tell us that they have a CBCT machine, you should be in a position to ask the concerned person, like, what is the FOV of their machine? Because some machines will have a large FOV, like 16 into 17 centimeters, which will help us capture the entire skull in one shot. Okay, some machines will have a small FOV of 5 into 3 centimeters, which will be very useful just to cover just 2 or 3 teeth in one CBCT examination. So when our area of interest is only such a small area, it is not advisable to expose the patient to a very large area of radiation. Radiation increases, point one. Second, with larger FOV machines, the voxel size keeps going up, meaning the resolution is going to be compromised. So when you're taking a scan for the full skull, the root canal morphology will not be very, very clear. But if your intention is only to visualize the root canals, go for a smaller FOV scan. So you should ideally check with your CBCT center what sort of FOV is their machine and is it customizable, because there are lots of cheaper machines which work on a standard FOV. 8 by 8. It will cover both the maxilla and mandible in one shot. It's fine for implant planning, but not advisable for finer, intricate processes that you want to see, like your root canals, or if you want to see the relationship between the nerve canal and the impacted third molar. For all those reasons, I would advise you to go in for a focused FOV, because that will improve the resolution of the scan. That's the whole idea. Okay. And also, you should talk to them on what are the options of reducing noise. Noise is nothing but an unwanted signal in the image. Supposing the patient has a restoration or a root canal treated tooth, you should check with the centers on what sort of noise reduction protocols they have in their machine. These are all built into the machine by the manufacturer. So we don't have much of control over them. So it is very essential for us to have in mind on what was the protocols being followed by the center to reduce the noise. And one more thing that you must keep in mind here is, as you increase your FOV, you are also increasing the noise in the image. So that is why, once again, I'm telling you, try to take images only for the region which is of clinical interest to you. Just see here, have a look at this. This is a very, very low definition, or this is ultra low definition image, and this is a HD image. See the sharpness which is there here. I can appreciate the periodontal ligament very easily, but here it looks a little hazy. we can still get the details, but we might need a little bit of prior experience or a training to further decipher the image. So our aim is to make image reading easy, because this is just one step in preliminarily planning treatment for the patient or in monitoring the outcome of your treatment. So make sure the imaging is done with the best possible facilities available in and around us, so that we are able to eliminate any sort of a subjective bias when we are deciding on the diagnosis or outcome of the treatment. Yeah, this is just a slide to summarize how the quality of the image changes. Okay, I've used two terms here, 400 microns and 70 microns. This is basically the voxel size. Okay, let me introduce you to the concept of voxel. All of us, when we were kids, we would have played something like mosaic art, wherein we placed stickers of the same color adjacent to each other, and we were able to reconstruct an image. In this manner only, any computer or any mobile phone or any DSLR camera is going to store your images. All right. So the what do I mean by this the voxel sizes? Unlike the cameras where we measure it in terms of the number of voxels, in cases of CBCT, we measure it by the size of the voxel. Smaller the voxel size means more voxels can be packed in that space. So remember, a small voxel size refers to a high definition image. Okay, so here you can see at 400 and 70 microns. 70 microns is what we'll be using for very precision sort of things, such as a root canal or relationship of a nerve nerve to a impacted tooth and all that. 400 microns can be used for our conventional implant planning stuffs. So here the resolution is high, but here the 400 microns resolution is low. Image noise is more as your resolution is lesser, but at 70 microns the image noise is less. Radiation dose is lesser, but in 70 microns radiation dose is higher. So whatever is green is actually favorable to us. So when you take an image at a high resolution, implies that your only compromise is you are giving a high dose of radiation to the patient. So that is one thing that you must keep in mind. But at 400 microns, radiation dose is lesser. So ultimately, to sum up CBCT, when you're advising for CBCT, you have to be a little careful about two things. One, the FOV, which you are asking for, because it should just be slightly larger than the region of your clinical interest. Don't unnecessarily take a scan for the full skull just because the clinical purpose is just an implant planning in one quadrant or one arch. Please don't do that. And also look at the resolution of the image. If you're planning to do something in endodontics or root canal, canal proximity to third molar, go for the smaller voxel size or a high resolution image. CBCT also allows us to do some specialized slicing, like as for temporomandibular joint, the condyles alone can be separately visualized. We have a separate case on this to discuss on a little further down. So there are separate slicing options are also available with CBCT. But remember, CBCT is not a one-stop solution for all our imaging needs. One of the main problems is the presence of artifacts. Unfortunately, the artifacts are nothing but noise. As you can see here, there's a crown here, and you can see there's a lot of scattering or white lines running out from the crown, which is slightly higher than what you would see with a CT scan. There are different types of artifacts, which is beyond the scope of us, but please remember that this is all not a normal sign. So to minimize artifacts, choose your FOV and your voxel size optimally. So just in case, if I'm going to take a scan only for the front two teeth, if we take a full art scan, we'll end up having artifacts from these metals also coming out here. But we can just take a scan only for the lower front two teeth. That way we will minimize or completely eliminate these artifacts coming up from these teeth which are crowned. Okay, this is another type of artifact, ring artifacts. Ring artifact happens because of poor calibration of the machine. And this is a motion artifact, which happens because when the patient tries to move between or during the scan, which can happen with the pediatric population. So CBCT indications, limitless. It's because earlier, when it came up in the early 2000s in our country, it was mainly used for implant imaging, but now it's being used for impaction assessment, endodontics, airway assessment, so on and so forth. Let's move to the second case. So please remember, CBCT is not the one-stop solution. The cases to follow will show you there are scenarios where CBCT is not very useful. Here we have a 56-year-old male patient who had a history of tongue cancer, now reports with pain in the third quadrant. Here you can see, apparently he has given up his habits because this is how he presented. There is no nicotine stains. And here in the right side, we can see that some sort of a partial glossectomy has been done. But the patient reported with pain in 3-6, 3-5, and 3-4 region. What could be the cause? Well, clinically, TOP was positive, attrition is there, and some amount of isolated mobility was there. A grade 1 mobility, meaning, so you can see that there is not much of gingival recession. Of course, I don't have a buccal view here, but you don't see much of a gingival recession, but there was an isolated mobility in these three teeth. The rest of the teeth were all looking fine and intact. So we went for a normal OPG examination. Here we were able to elicit a periapical radiolucency, but something uncommon is usually periapical radiolucencies will not cross the mandibular canal because it's completely odontogenic. It tends to remain above it. But here it seems to have extended beyond the mandibular canal, going to the lower border of the mandible. Take a careful look here. It is not normal. There is thinning and slight displacement between the fragments, suggesting that it's a pathological fracture of the lower border of the mandible. We didn't go for a CT because the history was in favor. The patient had a history of tongue cancer. Of course, it was on the contralateral side, and we had a pathological fracture being present. We didn't go for a CBCT, but we went for a conventional CT. The soft tissue window of the CT shows a huge osteolytic lesion here. I'll show you the 3D reconstruction, which is much more informative. When you see a 3D reconstruction, we were able to see that the margins of the radiolucency are irregular, and definitively there is a fracture in the lower border of the mandible. So looking at these imaging features, two things get confirmed. One, it's an aggressive lesion because only aggressive lesions will have this sort of a irregular border. Your cyst will not have any sort of an irregular border. It will tend to have a smooth border in the bone because it grows all along the sides and it's a slow growth. But here this is eating into the bone. And second point that we see is there's a confirmed pathological fracture of the lower border of the mandible. So looking at these features, considering his history, we were a little doubtful because this doesn't look like a simple radicular cyst. Is it a second primary or is it a metastasis from a site elsewhere? When it comes to cancer patients, you'll have to be careful about one fact that there's something called as field cancerization. In this case, the patient had a lesion on the right side of the tongue because of his usage of tobacco habit. Apparently, that side looks apparently normal, but here on the left side, the patient's got a lesion. What has happened in this case is the patient has been exposed to the tobacco product. I mean, the entire aerodigestive tract has been exposed to it. So because of that, multiple areas in the oral cavity would have developed some sort of a pre-malignant change that could lead to the development of one cancer on the right side of the tongue and something else on the left side. Or is it a primary that is present elsewhere and that is metastasized to the mandible? So we had also done a PET scan, but before that, let's see a brief overview of the CT scan. The CT scan, just for academic interest, was invented in 1971. Godfrey Hounsfield and Alan Cormack were the people primarily behind it. It also works in the same manner as that of your CBCT, but only difference is it has to rotate several times around the patient. And one more interesting fact here is The CT scan can give us the nature of the internal constituents of the lesion through its Hounsfield units, which our CBCT scans cannot give. The first generation of CT scan had a single detector. It took a really long time. But now the current generation, slowly the detectors have become larger and larger. And now we have wider array of detectors. Okay, and CT scan can show soft tissues also to a certain extent. So this is from the same patient. This is a bone window. This is a soft tissue window. Here in the bone window, you are able to see that the soft tissues appear as uniformly as one gray shade. But here in the soft tissue window, we are able to see some planes between the different soft tissues. So if there is a thickening of some muscle plane, muscle mass, that can easily be detected. The whole thing is we are trying to pull out our eyes at any point of time can detect only about 50 to 54 shades of gray. So we are just trying to pull out those shades of gray which are pertaining to bone when we want to visualize the bone and pertaining to soft tissues when we want to visualize the soft tissues. Just some differences between CBCT and CT is CBCT can operate only at a kVp of 90 to 100, but CT can go up to 150 kVp. What does this imply? Better soft tissue resolution. This we would have realized in our conventional IOPS itself. When we want to see the periapical regions, we're looking at periapical pathologies, we can keep the kVp at around 60 to 65. But when you want to see the alveolar bone levels, we have to ramp it up to 65 to 70 kVp. So when you want to see finer shades of gray, we will have to slightly increase the kVp a bit. And of course, this has 180 to 360 degrees. CT goes around the patient several times 360-degree rotations. So shorter scan times. And of course, the detector also varies. This is a flat panel detector. This is a multi-array of detector. So shorter scan times with CBCT. This gives only output in form of grayscale values, while a computer tomography will give it in the form of Hounsfield units. Okay, so a CT can mainly be implicated to look into hard tissue pathologies like cyst and tumors, for assessment of maxillofacial trauma, for TMJ pathologies, and implant assessment. Of course, for implant assessment, CBCT is available. That's why I put it up as the last indication. So please remember, when you're coming across a patient where you're suspecting some sort of soft tissue involvement also in the lesion, or you're expecting to see something into the sinus, or you're seeing a patient with maxillofacial trauma where brain also could have been involved, please don't advise a CBCT. Go for a computed tomography scan. Okay, so this is what, again, just to show you that this can beautifully delineate the expansion. Here, this is an unilocular expansion wherein a small tooth is present. Sinus opacification is seen in this radiograph. We also have contrast, which is not available with CBCT. Here, what we do is we introduce iodine-based contrast, and this will help us delineate on the vascularity of soft tissue lesions. Since we don't deal much with soft tissue lesions in CBCT, we don't do a contrast imaging, but here in CT, we tend to do all that. Going back to that case, whether it is a second primary tumor or is it metastatic lesion, that was our concern. So we went in for a PET scan, and the PET scan shows only an uptake in this region. Okay, in PET scan, what we do is we inject a radioactive nuclide and we try to map the movement of that radioactive nuclide in the body. So here it is very clearly evident that this is only concentrating or localizing in this left mandible. Of course, thyroidinol might take up since it's an iodine-based, it's got some amount of iodine in that, and there's a bladder will also be concentrated because the radionuclide will eventually get eliminated into the bladder. But this clearly shows that we are looking at a second primary tumor only and not a metastasis, because if it's going to be a metastasis, the management has to be different. If it's a second primary, yes, a surgical management will beautifully help us out. So that is what is the advantage of a PET CT. It is like radio-labeled glucose is used, and this radio-labeled glucose, when entering into the body, will tend to emit radiation, gamma radiation, which can be captured by the gamma cameras, and they will try to map the exact spread of the radionuclide in the body. Coming to the third situation, this will be something that we will practically see in our everyday practice. a patient who is partially edentulous. And what would be our first imaging? Okay, patient says, I want to have a fixed replacement. I don't want any sort of a removable denture. Our choice to them will be an implant. So when you are planning for an implant, obviously our first choice of imaging is going to be a CBCT. We take a CBCT, the sectional slices, we can simulate an implant placement also, as is being shown in this picture. But how do we go to this particular area again in the patient's mode? Because here when you simulate it in the slice number 173, 175 and 177, we are able to see that the implant is slightly buccally tilted so that we can get maximum amount of bone and we are able to place it. But how do we go back to the same site in the patient's mouth? See, here you have beautifully planned implants, but how do I go back to the same sites in the patient's mouth? This is where dynamic navigation comes into play, or a guided surgery or a digital dentistry comes into picture. So guided surgery is nothing but it has to reflect a patient specific anatomy in the guide. So it requires a clinical scanning followed by a radiographic scanning, and then the implants are planned on a prosthetically driven basis, and the entire details are integrated together to generate these sort of guides. So what exactly happens? You do print a guide like this, which will have a specific marker wherein you can that will act as your surgical stent when you're placing the implant. Like, I'll just summarize the workflow briefly. This is how the clinical scenario is. You take an image of this, you take a scan of the bones, you take a scan of the denture, and you superimpose this. This is your diagnostic wax-up. Here, basically, what you have done is a diagnostic wax-up and you have created a denture. So I want all the teeth to be in this position. So you're trying to make it a little more prosthetically driven. And then along the central axis of each tooth, we try to prepare for an implant. So this is what is digital dentistry and a workflow. But for digital dentistry to be effective, either you should have a dual scan protocol, as in like what you see here, scan of the teeth, the denture, it's scanned separately and that is superimposed in the patient's alveolus, or you should have an intraoral scan of the patient and you translate and superimpose this bone scan over the intraoral scan and you try to plan for the implants. Okay, let's go to the next scenario. Pain in the jaws for 4 years, of course, a patient in the second decade of life. And OPG was taken since the patient complained of pain in the jaws, and since the joint space has been told. So on seeing this OPG, we are able to appreciate one thing, that you can see that there is a slight enlargement of the head of the condyle on the left side. Right side seems to be normal. However, that's a little relative. Somebody could say that the right side is showing degenerative changes and the left side looks normal. That is also possible because in dental radiography, it is always advisable for us to compare side A with side B. Okay, so I can compare and say that left side is larger, or I can also compare and say that the right side is smaller. Well, this is where again, we had taken a CBCT with TMJ specific slicing. One thing that I can appreciate here is the right side condyle looks normal in its morphology. But here, the left side condyle, this is not the normal morphology. A condyle should have a smoothly rounded surface, but here it seems to be having a little irregular surface as what you can see here. So this is not something normal in this particular coronal view, but the sagittal view seems to be okay. And here also you are able to see that the margins of the condyle are not very, very smooth. Okay, so we from the CBCT scans, we thought that there was something wrong in the left side condyle being slightly larger. So we went for a specific nuclear scan for the head and neck region alone, which showed an increase in the uptake in the left side of the condyle. Right side of the condyle shows lesser uptake. Condyle has got a growth plate in it, which remains active for almost up to 30 years of age. So here the growth plate on the left side seems to be a little more larger than the growth plate on the right side. This in turn implies that the condyle on the left side seems to be growing a little more faster. So this seems to be a case of a condylar hyperplasia. Okay. So it's a case of condylar hyperplasia that we do get to see here. Okay, now come to a next scenario. A 43-year-old gentleman complains of pain in the oral cavity and the jaws for the last 2 years. Looking at his status, he's got some crowns in them, and he's got, of course, a metal crown and metal ceramic crowns here and there. He also reported of pain while opening and closing the jaws. Why I wanted to bring this picture into consideration was that the patient has got multiple restorations which are there bilaterally, some of them opposing each other. So could it be something wrong with the temporomandibular joint? Yes, two OPGs of the same patient taken at different time spans shows severe flattening on the right hand side of the condyle, while the left condyle seems to be pretty much normal. So since there was an associated click and other features, we went in for an MR imaging. So this MR imaging here shows that in the disc seems to be in the closed mouth position itself, the right side disc is ahead of the joint. The left closed, see where the position of the disc is, but here it is right in front of the condyle. Normally in the mouth closed position, the disc should be slightly above the head of the condyle, not in front of the condyle as you can see here. So this is a case of an anterior disc displacement. Why I brought in this picture is MRI can be used to visualize the soft tissue structures of the oral cavity very, very clearly. And the disc being a soft tissue structure, it is very useful in visualizing the temporomandibular joint. Just for academic interests, MRI scanners were introduced in 1972 and 73. Just 1 year after CT scan was introduced, these two happened to be the big revolutions in medical imaging, because one CT imaging could be used for all the hard tissues and MRI could be used for soft tissues. MRI does not use ionizing radiation, so it is very, very safe. It just uses a magnetic field and an RF pulse to produce an image. It basically plays with the water molecules or the hydrogen atoms of the water molecules to produce the image. Normally what happens is these hydrogen atoms have a tendency to behave as a spinning bar magnet. When placed in a magnetic field, they tend to rotate or align themselves in one particular direction. So when the magnetic field is placed along the z-axis, all the molecules will tend to align themselves parallel to the z-axis. When an RF pulse is applied at right angles to it, the magnet will lose its control over the hydrogen atoms, and slowly, progressively, the hydrogen atoms will flip into the x-axis orientation. That is, they will tend to align themselves parallel to the RF pulse. When it does, it is going to produce a signal, and which can be used to recreate the image. When it comes to MRI, remember there are two image concepts that are there. One is T1 images and T2 images. T1 images, the fat content and protein-rich fluid appear bright, while in T2 it is water, inflammation. So it can be used to detect inflammation of smaller structures such as your discal inflammations and others. Hemorrhage into the joints can be detected. And remember, but please keep in mind the bone signals are very, very bad with MRI, because both in T1 and T2, the bone appears dark. So there is limited information if it's going to be a fracture. So in dentistry, we will be using MRI only for discal pathologies and for salivary gland related pathologies. That would be the main indication for an MRI here. So this is again an MRI of the brain, which can be used. Of course, in brain, it's used left and right and extensively. But for us, it's mainly for our disc and glandular pathologies. And in case there's a soft tissue tumor, it can help us differentiate between benign and malignant, but per se, it is not taken as a gold standard, as biopsy is considered a gold standard. So we don't look into it much. However, MRI cannot be used in patients who have aneurysmal clips and heavy metal tattoos. Pacemaker is a relative contraindication, for it can be switched into a MRI safe mode when a patient is to be subjected for an MR imaging. Coming to the last scenario before we summarize all the imaging modalities. Here we have a middle-aged lady who complains of pain in the floor of the mouth. mealtime syndrome was positive, and she also had a swelling in the floor of the mouth. Mealtime syndrome meaning whenever the sight of food was there, the pain increased. Swelling. So initially we thought it's some salivary calculus which is causing an obstruction to the salivary outflow, which is causing the trouble. We went in for a CT scan. Multi slices of CT scan do not show anything very significant. There is no calculi in the floor of the mouth. The floor of the mouth appears relatively free of any radio opacities. Then we went in for an ultrasound of the floor of the mouth, which revealed a hypoechoic mass arising from the tail of the submandibular salivary gland, which was present corresponding to the anatomical site where the swelling was present. So it is not a calculi as we presumed it to be in the first clinical examination. It turned out to be a benign salivary gland. A sort of a swelling. So we are not yet sure of what it is. We'll come to it later. So what we did here was an ultrasound. How does ultrasound work? Ultrasound sends different waves or ultrasonic waves into the tissue, and based on its reflection, it's going to reconstruct the image for us. So this actually happened to be adenoid cystic carcinoma, a carcinoma arising from the mandibular gland, which usually arises from the minor salivary glands. This is a little rare for it to arise from the submandibular gland. So just for academic interest, what appears white on a CT, we'll call it as hyperdense, but the same in CBCT is radiopaque. MRI, it's hyperintense. Ultrasound, it's hyperechoic. Black is going to be hypodense. CBCT is radiolucent. Hypointense for an MRI and hypoechoic. And when it comes to PET CT or scintigraphy, it's only in terms of hot spot and cold spot that we speak about. So just to conclude and summarize all the imaging modalities. So we discussed about CBCT, CT, PET CT, MRI, and ultrasound. So ideally, you will use, if your problem is only pertaining to the dentition, go with CBCT. If you feel that it is something extending into the bone with a probable soft tissue component, go for a CT or a contrast enhanced CT. And if you feel it's an exclusive soft tissue pathology, like that of a disc or a salivary gland, go for an MRI. And if you feel it's something like, looking at metastasis from elsewhere, or you want to do a complete cancer imaging, go for PET CT. And ultrasound is something that you would use only for soft tissue pathologies exclusively. See, again, we have here a wide array of imaging choices, but your imaging has to be decided only based on the clinical requirements. And there's a lot of personalization that is required here in the individual judgment making, because it is not always that though I'm saying that CT is can be used in these situations, still based on the individual scenario, you will have to decide where it would ideally be appropriate. Because imaging in isolation is just a maya. It is not going to give you the complete information. But when you combine it with the clinical data only, it makes it for a holistic decision making. And again, imaging is one step in your diagnosis and in evaluating the outcome of treatment for a patient. So with this, I would like to thank the organizers of Dental Rickshaw, especially Dr. Manikavasam sir and Dr. Matangi, who had been coordinating with me. Of course, earlier a date was fixed, and due to my personal reasons, it could not be handled on that day. And thank you, sir, for the opportunity.
Thank you so much, sir. That was really a wonderful and informative session, sir. Now the session is open for the participants to ask for any doubts if they have. Either they can unmute themselves and ask questions, or they can also ask in the chat box, whatever is easier for them. Shall we have it for 5 minutes, 10 minutes, sir?
Sure, sir.
Okay. The participants can unmute themselves and ask your questions, or you can put it in the chat box. I can see a few appreciations. Yes, please. Please carry on, ma'am.
Sir, we are taking MRI, no? T2, is it T2 or T1 weighted, sir?
Ma'am, usually when it comes to MRI, T1 is something that shows a normal anatomy, and T2 is when you're suspecting inflammation. If normally when you write it for MRI of the parotid or any MRI, it will be T1 and T2 that will usually be done mandatorily by the X-ray center. And you can specially request for flare sequence, because if you're going to look at the discal pathologies, apart from T1 and T2, you can also ask for the flare sequence, which will help you delineate the amount of inflammation present in the disc. Because a normal T2 might not show subtle inflammatory changes, but a flare will help us identify any sort of subtle inflammatory changes. Suppose another instance when we go for an MRI is in parotid gland swellings, mainly because again, we would want to see the proximity to the facial nerve. There also going in for a flare sequence will help us pull out the course of the facial nerve through the parotid gland, which will help in planning the surgical incisions accordingly.
Thank you, sir.
Thank you.
Sir, one question I've been
Yes, sir.
hearing in every session, what is the relevance between the PFM multi-unit bridge and the MRI? If somebody is going for MRI for some other reason, health reasons, and few say it doesn't matter, and few say we have to remove the PFM bridge and then we have to do it after the session. What do you
No,
think?
it is not required to remove it, sir. It is
Yes.
not required to remove it. It is not going to pull out the crown from that. Some movies we might have seen where the metals seem to go flying, but it is not that strong a magnetic field. So it is absolutely safe to do it. However, there will be signal artifacts, sir. That is one thing that we have to be concerned about. But that while interpreting, the radiologist keeps that into mind. Accordingly, only they slice it and give us. So it's not a major drawback, sir.
Yes, sir. It is the same for the full mouth rehabilitation also. Isn't the full mouth implants and the
Yes.
metal bars and all that? That doesn't matter, isn't it, sir?
Doesn't matter, sir. That's my personal opinion, sir.
Thank you so much, sir.
Thank you, sir.
And one more question, sir, regarding radiation. While pregnancy, if somebody comes for root canal treatment and they fear about taking intraoral X-rays for repeatedly, like 3 or 4 exposures during the root canal, and few articles say 10,000 X-rays we can take safely in a year. So what do you see in that, sir? What is
Sir,
your opinion, sir?
Yes, sir. Sir, very simple that our IOPA radiographs have very, very, very minimal gonadal dose.
Yes, sir.
Because we are going to target some area in the oral cavity, and the amount of scatter that would go to the gonads is going to be very minimal. So it's very unlikely that that would cause any sort of harm to the developing fetus. However, in case if the patient is apprehensive, we can always use a lead apron, because the scatter from within the patient will not reach the gonadal areas at all. Will not reach the gonadal areas at all. Maximum it will go up to the thyroid level. However, since we are working in an area where there could be scattered radiation, as there could be backscatter from the machine and others which should not go and come in contact with the patient can wear a lead apron, sir.
Yes, sir. There is a question here in chat box,
Yes,
sir.
sir.
If there is TMJ clicking or pain, how to decide between CBCT, CT, and MRI, sir?
Yes, sir. Sir, whenever the patient reports to us with TMJ clicking or pain, let's go with the plain OPG first.
Yes, sir.
And we take an OPG, we are able to see the amount of bony changes that is taking place in the head of the condyle. All right, sir. So supposing you feel that the condylar changes are inappropriate, like for somebody above 45 years of age, I see a flattening of the condyle. It is absolutely acceptable to me, sir. It's a form of osteodegenerative changes that happens during the aging of the individual. But if somebody is 30 years or 35 years and they're showing a severe bony degeneration, it might not be osteoarthritis. It can even be rheumatoid. So there, if you want to see the positioning of the disc, but all said and done, in spite of knowing where the disc is positioned, we have limited therapeutic options to reposition the disc or anything. So in case you want to see the position of the disc, you can go in for an MRI. But if you see severe degenerative changes in somebody in 20 to 40 years of age group, please go in for a rheumatoid panel evaluation also, because these days rheumatoid diseases are on the rise. Earlier, we were all scared about diabetes and hypertension, but yes, apart from that, now rheumatoid is also coming into prominence, and that is the decade when it really sets in, third to fourth decades of life. And we might be the earlier ones to see it also. So if you could identify it and hand them over to the rheumatologist, it becomes easier for them.
Yes, sir. And
So a few
another
interesting
general question.
questions.
Yes, sir. And the same question like how to select CBCT, CT needed for a case, sir. It's a
Yes.
general.
Yeah. As Dr. Sukanya has CBCT and CT. As I said, CBCT, if you're only looking at the teeth. If you're looking at a finer root canal anatomy, yes, CBCT. But if you're anticipating to see something that is extending beyond the teeth into the bone, like an oral cancer, rising somewhere in the alveolar region, which could easily extend into the lymph nodes and all that, because you can do a contrast CT. CBCT, you don't have a scope for a contrast. So you will have to go for a CT scan.
Lead apron does not cover hand. Is that okay, sir?
Hand, whose hand? Your hand or the patient's hand? No, sir. Because many a times you would ask the patient to hold the film or the sensor. Yes, that way I fully agree. But ideally, we should not be holding, neither we nor the patient should hold the film or the sensor. It's better to use our positioning devices, sir, which will be really useful. And they're not very expensive also. Earlier, it used to be quite expensive, but nowadays, some companies, when we buy the RVG itself, they give those paddles for us to hold the sensors, which are very easy. So technically, we can practice radiography without an additional assistant. We hold the sensor through the paddle and then point the X-ray cone at the site of thing. It does its role pretty normally.
Sir, angio patients with the stent and radiation.
For MRA, yes, sir, you will have to be a little cautious. But usually, number case, we're going to take an MRI only for the head. We are not going to go into the chest or the thorax region, so we don't have a problem. So, but other, if they have some sort of stents in the carotid arteries, there are scenarios where they're placed there as well. So, அப்படி இருந்ததுன்னா, then we'll have to be cautious about the MRI for a TMJ case, because those stents may tend to move or dislodge. There is a school of thought where they say after about 6 months, the stents get epithelialized, so they don't move. So otherwise, we will have to be cautious about it. So.
Okay, sir. I think that's all the questions. Anyone with any questions? Or we can still ask in the group. I can get the answers from sir and then I'll get back to you. So I think we can conclude here, sir. So thank you
Yeah,
so
thank
much,
you,
sir,
sir.
for the informative session, sir. It is
Thank you,
very
sir. Thank
practical
you.
to understand, easy and relevant for our day-to-day practice, sir. Thank you for the
Thank you,
time
sir.
and knowledge sharing, sir. Thank you so much, sir.
Thank you, sir.
Thank you so much. Thank you, participants. And one more question is there, sir. I think
Yes,
it's
sir.
some
On
portable
portable
X-ray.
X-rays. Yes, I was very much expecting it. Portable X-rays, yes, because they are very, very useful for us, sir, because single-handed DC machines. But unfortunately, there are a lot of machines which have not received ARB certifications also being sold in the market. So please make sure that the machine has been certified by AARB, because with portable X-rays, the only concern is their backscatter, meaning the X-rays go through the front cone. But during the eventual X-ray production, there are some X-rays that come out of the machine towards us where we are holding it. So the machine should have a lead shielding inside it. And that is usually tested by ARB. And some brands, when they sell it to us itself, they show that their product has been approved by ARB, which has a lead lining inside them, because it's not possible for us to evaluate it whether there's a lead lining inside or not, because that is some completely assembled. And most of these portable machines are not something that is easily dismantleable also, like our conventional X-ray machine. So that alone you can please make sure. And there are brands in the market which are being sold without ARB certification also. So that is one thing.
Yes, sir. Okay, we can finish it now, sir. Thank you so much,
Yes,
sir.
sir. Thank you,
Have a
sir.
great day, sir. Thank
Good
you.
day, sir. Thank you.